One of the key changes is this paradigm shift from assessing asthma severity to assessing asthma control. So in the past, as you all know, we classified asthma based on whether it's mild, moderate, or severe. And there was this table which we had to remember and classify patients or pigeonhole them into these classifications. But now we know that asthma severity will change over time and depends not only on the underlying control, inflammation, but also it depends also on patient compliance, trigger factors, and other aspects. So the shift is now away from classifying our patients correctly to now assessing whether or not they're controlled, which is more important. So this table is now meant more for research purposes, and we don't usually advocate it anymore for in the CPG. What we have come up with is this table of control, which you all have seen again from the previous speakers. And I agree with Prof. DK, it's quite hard to remember all these 6 domains. So like what Prof. Che has said, it's easy to remember whether they are totally controlled or they are having exacerbation or whether they are somewhere in between. But our goal is still to get them into the green zone, okay, your asthma control or the WAP, into the green zone of the WAP. So to help them get into the green zone, again, we need to engage our patients. And the previous speakers have already alluded to the need to guide patients in telling you how they are at the moment. So as in any chronic disease, we like patients to play an active role in their own care. And this is where the WAP comes in. And you just heard about how it's being used. As we all know, there are many factors involved in poor asthma control and poor outcomes. There could be drug factors. Either they don't like the inhaler, they don't like the regime, it's too costly, too many side effects. Or there could be non-drug factors, and there are many I've listed here. I won't be going through all these factors that relate to poor asthma outcome, but what I'll do is I'll tell you what I think is a very important factor, and this is what I call the asthma disconnect. An overestimation of asthma control by patients. That means your patients will come to you and say, "Doctor, I did not have any attacks since the last visit, and I feel okay as my reliever is still working." Okay, so they'll tell you that they're well. Oh, no attacks, and my Ventolin is working. And on our part, an underestimation of patients' symptoms. That means we underestimate the symptoms. When we examine them, "Oh, you look quite normal today. I don't hear any wheeze, so you must be okay." So it appears that the two parties are trying to collude and come together and say that the patient is okay. But the problem with this is that there's no objective assessment of that. One party say "I'm okay," the other party say "you're okay," so they both agree. The next thing we know, they end up in hospital, or to tell the truth, they may even die of asthma. Okay, so unfortunately, despite our advances in asthma care, more than 100 deaths still occur locally every year from asthma. So the problem with this is that there's no objective assessment or measurement of asthma control. So what is asthma control? How can we help patients achieve and maintain control? How do we know when asthma control has been achieved? There are many domains to asthma control, and I've listed here some of the more important ones. The problem with all these domains is that they don't all agree with one another. They don't all tally with one another. That means the correlation with asthma control is not in the same direction for all of them. What we need is a tool that accurately assesses asthma control, something that's simple to perform, validated, objective, preferably with a numeric target that's easy to remember, something that can be used by patients as well. And as Prof. TK Lim has mentioned, there are various questionnaire tools to assess asthma control. And here I've listed 4 of them. The Asthma Therapy Assessment Questionnaire, the Asthma Control Scoring System, the Asthma Control Questionnaire or ACQ. This one requires peak flow measurement. And finally, the Asthma Control Test or the ACT for short. This one doesn't require peak flow measurement, has been validated. It's simple and easy to use. This is what the ACT question looks like. If you can just take the ACT that's right in front of you on the table so that I can talk you through it and basically get you have a real look at it. Can I just have a show of hands? How many of you have used ACT in your practice? Anyone has used ACT? Okay, not the majority. In fact, less than 30% here have used ACT. The ACT has, for the adults, has 5 questions which look at the last 4 weeks asthma control. So these 5 questions pertain to time off work or school or unable to do home activities, shortness of breath, nocturnal symptoms, need for rescue medication, rescue inhaler, and one's own self-rating of asthma control. So 5 questions and a score of 1 to 5 for each question. So you can have a minimum score of 5 or a maximum score of 25. Okay. This should be done preferably by the patient. It's available in English and all the languages, and it's very simple to complete. How do we interpret the ACT score? Basically, a score of 20 to 25 is good, 15 to 19 inadequate, and anything below that is poor. Or another way to remember is 20 to 25 is good or well controlled, and anything below that is not well controlled. What are the possible actions that you can do? A perfect score can step down for at least 3 months and monitor their control in that 3 months. A good ACT score, maintain the current therapy or regime. And an inadequate or poor ACT score, you need to step up therapy to get them to the target of 20. Yeah? And if someone who has a persistently poor ACT score, less than 15, you must consider why is this so, and they may need a specialist review. So very simple, in our CPG, we've come up with this ACT-guided algorithm. Basically, 20 and above, maintain or step down. Below 20, step up. And how to step up based on the 5 steps which Prof. Lim has mentioned to you. So this ACT or asthma control test is validated. It's easy to use. There are cut-off points which help to differentiate between well-controlled and inadequately controlled patients. And what's good is that it's a numerical target that both patient and doctors can aim for. So in the past, when both of us assess asthma patients, we are not speaking the same lingo. You may say the patient is not well controlled, then when he comes to me, I say, oh, he's actually quite well controlled. Or vice versa, you may say that he's well controlled, but when I see him, he's not well controlled. So now we have a single similar tool that we all can use, which we are promoting for at a national level, so that we all speak the same lingo. If you tell me his ACT score is 18, I'll know exactly what it means. His ACT score is 15, I'll know exactly what it means. Rather than in the past when you say, oh, he's moderately severe and exacerbating, or he has uncontrolled asthma and with admissions to A&E. So we rather use a single numeric digit and all of us say the same thing. So this tool is actually recommended by Gina as one of those that has the potential to actually improve asthma care and improve patient-doctor communication. Some background validation studies. This was the original study that validated the ACT questionnaire. Basically, they got a group of specialists to rate patients' asthma control, and they got patients to fill out the ACT score. And you can see that the correlation was quite smooth, quite good. This is data from a very large study called the GO study, which looked at patients with asthma of all degrees of severity, mild, moderate, and severe, and looked at the ACT score during the study, during the 1-year study, and the outcomes of asthma. So you can see that a very poor ACT score correlated with a high risk of requiring oral steroids, hospitalization, emergency visit over the 1-year period of the study. Whereas a very high ACT score, or a good ACT score, had a very low risk. So this was a prospective validation of the ACT study. This is another study done in Hong Kong by Christopher Lai, which looked at patients' ACT score and correlated it with the risk of unscheduled hospital contacts in the past year. So this was like retrospective correlation. And again, they found the same thing. Patients with a low ACT score, high chance of hospital contact in the previous year. Whereas good ACT score, low chance of hospital contact. So Prof. TK has mentioned that we should use ACT just like a BP monitor or HbA1c or a lipid level. Now that we are promoting chronic disease care strongly in Singapore, we want, just like in hypertension, we want to obviate all the peaks in blood pressure and get them into a good or satisfactory blood pressure zone. What about asthma? How can we get them into the green zone? So asthma, by its very nature, is chronic, it's dynamic, and it responds to various triggers and compliance and other issues. So it's quite heterogeneous. Similarly, we want to get patients into the green zone. And the tool that can help us do that is the X score. Okay. Easiest to remember, patient does it, don't need to remember many things. Basically, like the web, we can use the X score to help improve asthma care. So to summarize, the emphasis of our guideline is a lot on clinical control. And the CPG recommends ACT monitoring to maintain control. So the ACT is practical, robust, and validated. It should be done by asthmatics themselves at zero cost. It's free, it doesn't cost anything. And scores may be used as a treatment target. So I would say in managing asthma, there are just 4 main things that we can do that will help go a long way. Develop a written asthma action plan. Use preventive medication daily, i.e. more preventer, less reliever. Avoid triggers. And assess control by using the ACT. So with that, I thank you for your attention.